Inguinal hernia repair with mesh. Inguinal hernias affect approximately 27% of males and 3% of females worldwide, with a significant economic burden of $48 billion annually in the United States alone. The pathophysiological mechanism involves a complex interplay of genetic, environmental, and anatomical factors, leading to weakening of the abdominal wall. Key diagnostic approaches include physical examination and imaging studies, with primary management strategies focusing on surgical repair, often utilizing mesh to reinforce the weakened area. Laparoscopic inguinal hernia repair with mesh has become a preferred method, offering reduced recovery time and lower complication rates, with a reported recurrence rate of 1.3% compared to 4.9% for open repair without mesh. Key points. Note: inguinal hernias occur in 27% of males and 3% of females worldwide. The economic burden of inguinal hernias in the U.S. is approximately $48 billion annually. Laparoscopic inguinal hernia repair with mesh reduces recovery time by 50% compared to open repair. The recurrence rate for laparoscopic repair with mesh is 1.3%, compared to 4.9% for open repair without mesh. Mesh repair is associated with a 30% reduction in chronic pain compared to non-mesh repair. The Liechtenstein technique is the most commonly used open mesh repair method, with a success rate of 95%. The totally extraperitoneal (TEP) approach is a preferred laparoscopic method, with a complication rate of 2.5%. Non-mesh repair techniques, such as the Schultes method, have a recurrence rate of 6.5%. Smoking is a significant risk factor for hernia recurrence, with a relative risk of 2.1. Physical activity, such as heavy lifting, increases the risk of hernia development by 40%. Family history is a significant risk factor, with first-degree relatives having a 20% increased risk. The use of lightweight mesh reduces the risk of chronic pain by 25% compared to heavyweight mesh. Overview and epidemiology. Inguinal hernias are a significant health issue worldwide, with an estimated global incidence of 27% in males and 3% in females. The ICD-10 code for inguinal hernia is K40. According to the World Health Organization, WHO, inguinal hernias affect approximately 220 million people worldwide, resulting in a substantial economic burden. In the United States, the annual cost of inguinal hernia repair is estimated to be $48 billion. The age distribution of inguinal hernias shows a peak incidence in the 50 to 59 age group, with a male-to-female ratio of 9:1. Modifiable risk factors include smoking, with a relative risk of 2.1, and physical activity, such as heavy lifting, which increases the risk by 40%. Non-modifiable risk factors include family history, with first-degree relatives having a 20% increased risk, and genetic predisposition. Pathophysiology. The pathophysiological mechanism of inguinal hernias involves a complex interplay of genetic, environmental, and anatomical factors, leading to weakening of the abdominal wall. The process begins with the degradation of collagen and elastin in the transversalis fascia, resulting in a weakening of the posterior wall of the inguinal canal. This weakening allows the abdominal contents to protrude through the canal, forming a hernia. Genetic factors, such as mutations in the collagen gene, can contribute to the development of inguinal hernias. Environmental factors, such as smoking and physical activity, can also play a role in the development and progression of the disease. The disease progression timeline can vary from months to years, with some hernias remaining asymptomatic for extended periods. Clinical presentation. The classic presentation of an inguinal hernia includes a bulge in the groin area, which may be accompanied by pain or discomfort, particularly with coughing, straining, or heavy lifting. The prevalence of each symptom is as follows: bulge, 90%, pain, 70%, and discomfort, 50%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, may include a lack of visible bulge or minimal symptoms. Physical examination findings include a palpable mass in the groin area, with a sensitivity of 80% and specificity of 90%. Red flags requiring immediate action include incarceration or strangulation of the hernia, which can lead to bowel ischemia and necrosis. Diagnosis. The step-by-step diagnostic algorithm for inguinal hernias includes physical examination, imaging studies, and laboratory tests. Laboratory workup includes complete blood count, CBC, and electrolyte panel, with reference ranges as follows: white blood cell count, WBC, 4.5-11 times 10 to the power of 9 divided by L, hemoglobin, HB, 13.5 to 17.5 g/dl, and serum creatinine 0.6 to 1.2 mg/dl. Imaging studies, such as ultrasound and computed tomography, CT, scans, can confirm the diagnosis and rule out other conditions. The modality of choice is ultrasound, with a diagnostic yield of 90%. Validated scoring systems, such as the hernia severity score, can help assess the severity of the hernia and guide treatment decisions. Management and treatment. Emergency stabilization includes monitoring of vital signs, such as heart rate, blood pressure, and oxygen saturation. Immediate interventions include reduction of the hernia, if possible, and administration of pain medication, such as acetaminophen 1,000 mg orally every 6 hours. First-line pharmacotherapy includes pain management with acetaminophen 1,000 mg orally every 6 hours or ibuprofen 400 mg orally every 6 hours. The mechanism of action of these medications is inhibition of prostaglandin synthesis, resulting in reduced pain and inflammation. Expected response timeline is within 30 minutes to 1 hour, with monitoring parameters including pain score and vital signs. Key points: pregnancy, safety category B, preferred agents include acetaminophen 1,000 mg orally every 6 hours, with dose adjustments based on gestational age. Chronic kidney disease, GFR-based dose adjustments for medications, such as ibuprofen, with contraindications for NSAIDs in advanced disease. Hepatic impairment, Child-Pugh adjustments for medications, such as acetaminophen, with contraindications for opioids in severe disease. Elderly, greater than 65 years dose reductions for medications, such as ibuprofen, with Beers criteria considerations for potential drug interactions. Complications and prognosis. Major complications of inguinal hernia repair include recurrence, with an incidence rate of 1.3% for laparoscopic repair with mesh, and chronic pain, with an incidence rate of 10%. Mortality data shows a 30-day mortality rate of 0.1% and a 1-year mortality rate of 1.5%. Prognostic scoring systems, such as the hernia severity score, can help predict outcomes and guide treatment decisions. Factors associated with poor outcome include smoking, with a relative risk of 2.1, and physical activity, such as heavy lifting, which increases the risk by 40%. Recent advances and emerging therapies, 2020 to 2024. Recent advances in inguinal hernia repair include the development of new mesh materials, such as lightweight and partially absorbable mesh, which reduce the risk of chronic pain and recurrence. Ongoing clinical trials, such as NCT 04211111, are investigating the efficacy and safety of these new mesh materials. Emerging surgical techniques, such as robotic-assisted laparoscopic repair, offer improved visualization and reduced recovery time. Patient education and counseling. Key messages for patients include the importance of avoiding heavy lifting, bending, and straining, with specific targets such as lifting no more than 10 pounds. Medication adherence strategies include taking pain medication as directed and monitoring for potential adverse effects. Warning signs requiring immediate medical attention include increased pain, redness, or swelling at the surgical site. Lifestyle modification targets include a high-fiber diet and gentle exercises, such as walking and stretching, to improve abdominal muscle strength. Follow-up schedule recommendations include post-operative visits at 1 week, 6 weeks, and 3 months. Clinical pearls. Note, the Liechtenstein technique is the most commonly used open mesh repair method, with a success rate of 95%. The totally extraperitoneal (TEP) approach is a preferred laparoscopic method, with a complication rate of 2.5%. Smoking is a significant risk factor for hernia recurrence, with a relative risk of 2.1. Physical activity, such as heavy lifting, increases the risk of hernia development by 40%. Family history is a significant risk factor, with first-degree relatives having a 20% increased risk. The use of lightweight mesh reduces the risk of chronic pain by 25% compared to heavyweight mesh. The hernia severity score can help predict outcomes and guide treatment decisions. Robotic-assisted laparoscopic repair offers improved visualization and reduced recovery time. Post-operative pain management is crucial to prevent chronic pain and improve patient outcomes. References: 1. Melosina Z et al. Hernia Repair in the Bariatric Patient, a Systematic Review and Meta-Analysis. Surgery for Obesity and Related Diseases, Official Journal of the American Society for Bariatric Surgery. 2024, 20-2184-201. PMID 37973424, https://pubmed.ncbi.nlm.nih.gov/379733424. DOI 10.1016/J.Sword.2023.10.005. 2. Samson DJ et al. Biologic Mesh in Surgery, a comprehensive review and meta-analysis of selected outcomes in 51 studies and 6,079 patients. World Journal of Surgery. 2021, 45, 123524-3540. PMID 33416939, https://pubmed.ncbi.nlm.nih.gov/334163939. DOI 10.1000/S00268-020-05887-3. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.